Health in Hackney. I've had apologies for absence from Ossian Powell, who's the Chief Operating Officer at the Homerton. Congratulations to Georgina Dibber on her appointment as our new Operational Director here in Hackney. Welcome to Cllr Turbet-Delof, Mental Health Champion. Great to have you here. And I have also had apologies from Councillor Oggers Canley. Just the usual matters of housekeeping. This is a hybrid meeting. Please keep your microphones off unless you're speaking. When it's your presentation or your item, please keep your camera on. Please don't use the chat function. If you want to get my attention, please raise your electronic hand. Members of the press may be watching. We're being live streamed. We are being recorded. Declarations of interest. Sorry, slight technical issue there. We're just playing around with things. I haven't been notified of any declarations of interest, so nothing there.
Sorry, Chair.
Yes, Councillor Samatar.
I just wanted to very quickly say that I work for Hackney, City and Hackney Mind as a network coordinator and the Recovery College as a tutor.
Thank you, Councillor Samatar. We've got that noted. And so with that, then we can go to our first substantive item on the agenda, which is tackling inequalities in local mental health. We are very grateful to be joined by our colleagues in East London Foundation Trust. I can see Lorraine Sunduza, who's the Chief Nurse and Deputy CEO here, and I understand they've got a helpful presentation. And sorry for the technical issues you were having before, Lorraine, and also Dean Henderson, who's our Borough Director. There's a helpful presentation in the pack, and I think that was updated this afternoon with some more data, a data set as well. I don't know, is Paul Calaminas joining us, or is he sending his apologies? Paul's sending his apologies. So with that then, if I maybe hand over to Lorraine for the briefing, and then I think maybe over to Dean, and then we'll open it up for questions. So Lorraine, over to you.
Thank you. Good evening. So I'm Lorraine Sunduza. I'm Chief Nurse and Deputy CEO for East London Foundation Trust. One of my portfolios, I'm one of 3 executive members who covers inequalities. Myself, the Chief People Officer, and our Executive Director for Integrated Care. This presentation will be supported by my colleague, Dean Henderson, who is the Service Director for our City and Mental Health Services based at the Homerton. And essentially, our presentation covers 3 overarching topics, which should cover the issues that you asked us to discuss today. So Dean will kick us off talking about the local work that we're doing, which came about from our transformation of mental health services work. And then I will talk about the Mental Health Unit's Use of Force Act and the implementation within the trust, and then finish off with the patient care race equality framework, which we're part of the pilot trusts working with NHS England on that. So should I hand over to you, Dean? And Dean will be sharing the presentation. Apologies, my laptop failed to do that. Thanks, Dean.
Thank you, Lorraine, and thank you, Chair, and thank you for the invitation to present tonight. I'll endeavour now to remember how to share on Google. Bear with me for a second. That's not going to work. I'll try again. It worked in the pre-run, so. One more time.
We've all got the presentation, Dean. If you
want. Okay, well, I'll just see if I can. If you can see this in a second. If not, I'll rely on you looking at your pack. So can you see the presentation on my screen?
No.
No. Okay. Well,
Maybe we should just talk it
we'll
through and just
talk
alert
through.
people the page will be on. Yeah.
Yeah, no, that's fine. And just so I can assist everyone, this is the presentation. Is that right, Dean?
Yes.
That is, and we're with the version we've got, and I think everyone's got in the room, is the one that was distributed today again. So we've got that one. Okay, so far away with that one.
I'll talk you through my section. So it's as Lorraine explained, I'm going to talk initially about some of the local initiatives we've taken over the last year to address equalities in City and Hackney. But for the first slide really just sort of sets the scene. So since a key part of the transformation is that we address not just mental health in its simplest terms, but the social determinants of health and inequality. So addressing inequalities is really central now to the way we deliver our services and achieve our service goals. So within our neighbourhood teams, we have community connectors, specialist roles are linked into a number of communities in Hackney, Durban, I Remind, which is the Black community, and so on. And we also link into a lot of the system-wide work that's happening since post the pandemic. There's been a big push, as you know, around tackling health inequalities, and you see on the right-hand side of that slide the plan that was developed by the City and Hackney ICS some months ago, and we are part of those discussions and the work that's going on that wider agenda of equalities. So then moving on, and what I want to talk about most of all is a piece of work that started with a series of focus groups and led to a report in 2021, which is called Let's Talk. Now, you'll see there's a quote there at the beginning, which really which is from the report, which acknowledges the struggle we have in mental health to properly and fully meet the needs of Black, Asian and minority ethnic groups, despite knowing that we fall short, knowing that we often see BAME communities overrepresented in acute settings and formal presentations and so on, and unrepresented in psychological therapies. So that was the starting point for that report. They held in February, March 21 a series of focus groups across the 3 East London boroughs, and out of that work came the report. And so for the last year, we've had a working group led by our clinical director, who's also a consultant psychiatrist in our early intervention service, looking at how we can address the challenges and the recommendations from that report. So if we move on to the next slide, what I've done is
Dean, just before you do, so
Yep.
Let's Talk. This was a group of clinicians
This
from
was
East London Foundation Trust who were commissioned to look at
this
this.
was a service user-led piece of work. So we've got people participation workers who are service users themselves who led this piece of work, and it was about getting the views of service users about their experience of our services. So the focus groups, I should have made this clear, the focus groups were with groups of service users in each of the 3 boroughs, getting their experience and their recommendations as to how we can improve our services from their point of view, from the various Black and minority ethnic communities. So it's very much a service user-led piece of work, and we've taken, as a trust and as a directorate, we've taken this on as a challenge and as a responsibility to follow through. So coming out of this report, there are 5 key themes, and I'll just go through briefly talking about each of the themes and what we're doing in response to those, to give you a flavour of how we're trying to take this forward. So the first and really important theme was about being a service with cultural awareness, empathy and compassion. And then, so what they highlighted was that a lack of cultural awareness is a key issue, and that misunderstandings and a lack of knowledge about different cultures perpetuates stereotypes, reduces compassion and empathy. So they recommended that we should work on that. So we're just about to finalise, in terms of our response, a piece of cultural awareness training with the local voluntary sector providers, which we'll run on a train the trainers model in Hackney, and cascade through to our team. So an introduction to the whole area of cultural sensitivity, cultural awareness and cultural safety. The group that's been meeting has also highlighted some good practice which does exist within our services. Since over the last couple of years, our specialist psychotherapy service has had a regular race and privilege discussion group, which has picked up issues really post the death of George Floyd around how do we address those issues of race and privilege. Our home treatment team did a very successful cultural exchange day, which was about members of the team getting to know each other better in terms of their cultural background and experience. We have, and I think we may have brought them to this group before, some dedicated psychologists who work with minority ethnic communities to improve their access to psychological therapies, and they continue to be an important part of what we do. But they're also now working, following a presentation with DMT, to work with our internally to look at our community teams and other services, how we can respond to these challenges. So that they're working with us to help us work out how we take this forward. And there's been discussions in this theme around how we as white allies can support the work. So that was the first theme, about cultural awareness. The second theme was about improving accessibility. And some of the things that we've done is working very closely in our new neighbourhood models with a range of voluntary sector organisations such as Bicker Holland, Derman Mind, Ari Mind, the Egyptian traveller community, and so on. We also have a new approach to accessibility to the service. So it's called open access. So once someone's been referred to the service and accepted in the service, once they no longer need mental health input from services, they remain able to re-refer themselves to the service for 2 years. So they have open access to the service and ongoing support through groups and other things. So we know that one of the barriers to services for many people, and particularly young black men highlighted this in work we've done, is actually the whole referral process, having to go to your GP, having to go through formal routes of referral. So we've now got this open access model, which makes re-referral for people much easier. And seeing
that's just for re-referral though, is it?
So essentially the referral routes, yes, that's once people have been accepted as in the service, they have initially gone through that route of being referred by their GP or by another agency. But once they've been accepted, once we've provided them with initial input and support, and once they're effectively no longer needing any active input from us, they can remain able to re-access services at their own volition for up to 2 years. So it's re-referral, if you like, rather than not self-referral, but it does give that flexibility for people. A third theme that came through the report was about having welcoming community spaces where groups can come for services, come for mutual support and access support. So, and we just give 3 examples there of forums that we use. Core Arts, people will know about, very well known and accessible space. The Hatch, which is a facility just by Homerton Station, and St Mary's Secret Garden in Pearson Road. These are 3 examples of existing spaces we have that seem to be accessible and welcoming to these communities. And then the last 2 themes that came out were about accountability. So this is about holding our staff accountable for what they do and how they do it, and looking at the power imbalance, if you like, between professionals and service users, and issues about the complaints process when it's used, often being lengthy and complicated and hard to access. So the key things we're trying to do is get better at learning lessons from complaints on the theme of discrimination, and improving access and availability of advocacy for people who want to get their needs understood and met or raise concerns. And then the 5th and final theme that came through the report was around holistic understandings, a broader understanding of what mental health is. Participants felt it was a holistic understanding of distress, of mental health, was needed for both professionals and for the community to reduce stigma, increase understanding, and allow services to be seen in their entire service users to be seen in their entirety. So a couple of examples of pieces of work which we feel and this group feels is heading in that direction. Our carer strategy is very much premised on that approach, the new carer strategy, and we've got increased pharmacy input in our neighbourhood teams, which allows people to have good information about medication and side effects, to simple explanations and good education around the pros and cons of medication in a way that they can understand and that they can get their questions answered in the way that they need. So there's just a couple of examples where we're trying to move away from a more conventional sort of psychiatric model to a more open, holistic approach. And then on the last slide of my section, I've headed a glimpse into the future, and I want to talk a bit about our early intervention approach, which is for people with their first presentation of a psychotic illness, typically in late teens, early 20s, but can be older than that. And we also have an early detection service which intervenes even sooner, which is around when there are early signs in education services and so on of people who may be at risk of developing a psychotic illness. And what we're seeing is that we hope is beginning to change the experience of people from BAME communities, and that actually it's engaging with people earlier in their illness. As I say, it provides a very comprehensive package of care for 2 to 3 years, and it's a much more holistic offer with CBT therapy, family therapy, and so on. And that particular team has worked very closely and worked very hard to engage with the communities of Hackney to make those pathways and make the service feel accessible. And we're beginning to see a sort of change in the profile of who's using that service. And also, recent audit of that service showed that actually service users from Black and communities, both men and women, were accessing psychological therapies on offer, the CBT for psychosis, the family therapy, to a greater extent than white and other communities in that service. So there's a sense that actually people are getting a fuller offer, an earlier intervention, and we're hoping that that's beginning to sort of break those sort of classic cycles of fear and the reluctance and that people have from those communities of coming forward and seeking help by the experience of being engaged with early and being given a much broader, a wider offer. So hopefully that's a sort of a taste of what we need to do more of, and a glimpse of how the future might look as we get better at doing that. So,
Dean, if I've just understood you correctly there, what you're saying is that early intervention service, there's a greater representation, accessibility of the different communities. Whereas if you move more into the acute side, as it becomes more serious, there is an over-representation of certain communities. Is that right?
Right, and I guess you're talking about the phases of the illness. So what that service does is it engages with people very early in their illness, so that and a lot of the evidence is that their recovery is fuller and more substantial. So what we're hoping is that over time you're getting people whose experience of engaging with mental health services from that very early stage is much more positive and much more complete. And so it's almost a generational change, if you like. As time goes on, more people will have had that experience as their first experience of mental health services, rather than the people in their 40s, 50s, and 60s who who came into services when services work much more differently. So it's the beginning of a change, I think, in the way that we offer services and engage with those communities. Anyway, I'll hand over now to Lorraine to pick up on what's happening trust-wide.
Thank you, Dean.
Thank you, Dean. So just to start off, I'm going to talk about the Mental Health Use of Force Act. And I suppose to put it in context, violence and aggression, particularly within our mental health inpatients, is one of the most common and significant incidents that we have that has a huge impact not only on the staff but also on service users alike. And some of the issues that we're trying to address are linked to the management of violence and aggression. So Mental Health Use of Force Act sadly came about following the death of a young man in a London mental health services, following a prolonged restraint by the police, where there was an incident on the ward. The police were called, and sadly, he died under restraint. After many years, this was enacted in November 2018, but came into force in terms of what we have to do as mental health trust, but also and the police in 2022, so last year. And it's actually about reducing and ensuring accountability and transparency related to the use of force in mental health units. So when we say force, we're talking about restraints. So sometimes if someone is being violent, we have to hold people down. So anytime we put our hands on someone to restrict their movements, that is, we have to monitor that. Then there is isolation of a patient, particularly enforced isolation. We've got seclusion, which is something that we sometimes have to do if we feel that someone is presenting a significant risk to others, that we have got facilities to lock them in a room. The Mental Health Code of Practice sets out things that we have to do to make sure that we're monitoring people as if they're secluded. And then there's also giving people medication under restraint usually, which is what we call rapid tranquilization. Now, over the years, all the data has always suggested that these three areas of practice, you're more likely to experience them if you're from an ethnic minority background, and more likely actually if you're Black and if you're a man, right across the country and even beyond England as well. So the use of force is looking at all of that and making that data more transparent, and also making sure that all trusts across England are putting in place things to make sure that we're able to reduce this. So if we go to the slide that says core strategies in reducing restrictive practices. So these things, we call them restrictive practices. They restrict patients, and it's usually detained patients as well. So we have got a strategy in relation to managing, reducing restrictive practices that we've been doing for years, but now with the Act, it's something that we have to continue focusing on and being quite transparent with the work that we do. So there's 6 core strategies. Firstly, it's about learning together and developing our workforce. There's something about representation of the workforce, for the workforce to represent the patients that we serve, which is linked to what Dean was saying about cultural competency. There's something about people who also work, being aware of the issues that impact certain communities. However, this cannot just be at frontline. It also seeps through the whole organization up to and including the leadership, which is why through NHS England as well, we've got the Workforce Race Equality, which monitors making sure that our workforce is diverse as well. The second thing is data. So it's really important to collate the data, but there's something about how you look at the data as well to make sure that we're monitoring rates. Because as much as if we've got seclusion, if the numbers start going down, we could be happy about that. But actually, when we look closer, is it equal in terms of all the different protected characteristics? The third thing is leadership. Leaders have to really be engaged within this, both clinical leaders, but also trust-wide leaders, to make sure that we are also creating environments where staff are able to work in a safe way, so addressing the issues of violence and aggression, because you're more likely to have the restrictive practices if people are constantly exposed to risks. Then there's working with service users and their families, so that co-production as well, making sure that we're tailoring the work that we do and it works for our service users as well, and getting feedback about their experience of it. The next is trauma-informed care. So this is us being a bit more trauma-informed. We know that adverse, particularly childhood events, have an impact on how people behave. And sometimes our response to that behavior within our services can exacerbate people's distress. So making sure that our approach is trauma-informed so that we're not re-traumatizing people. And often, obviously, if you have to restrain someone, put them on the floor, maybe sometimes facing down, and forcibly medicate them, and then lock them in a room, that's going to be quite a traumatic experience. So we're then caught in that cycle of us trying to manage a risk, but further increasing the risk as well. And then finally, rigorous debriefing. Now, this is mainly related to when these incidents happen. How do we support our staff to have the conversation with the service user about their experience, but also with the staff as well, creating that environment for us to learn, to think about, could we do something differently? And if I go to the next slides with the data, so we've started to look at this data, and it goes to our boards as well, where we look at our restrictive intervention and restrictive practices, but looking at them through the equalities lens. And particularly for this, we looked at it related to ethnicity. So when we looked at the restraints, so that's holding people, so restricting their movement, we saw there wasn't that much disparity in relation to race. There wasn't that much variation. They were all within what we call the limits, considering the number. So we're still working on reducing having to hold someone, but still making sure that every time we hold, are you more likely to be held down if you're ethnic minority?
Lorraine, that data set though, we're looking at a 4-year period. I mean, does it sort of, has it evolved over that 4-year period? I mean,
there's some variation, but generally it has been quite steady, particularly from the percentage of the number of people who are admitted. That's why sometimes the data is not so straightforward, but it has been quite stable. There's some variation, some months in some units, but generally we've seen it being quite stable. The next bit is the seclusion. And particularly for City and Hackney, there has been a gradual increase. It has been increasing, particularly in relation to people from ethnic minorities. So that's part of the work that we're trying to do as well in our time to think space, which I'll touch on in a bit. And then finally, in our rapid tranquilization, again, City and Hackney, it's gradually started to increase as well.
So just on those two, where do we see the, just if we look at seclusions, where do we see the, so say people from an ethnic minority background vis-a-vis other backgrounds? How do we extrapolate that out from what we see on that graph?
So from that, I think what it is telling us that the rates of you being secluded are higher if you're from an ethnic minority. So those are the percentages. So you're more likely to be secluded and to be given medication forcibly. But
so what's the average though? Because I see the parameters being the dotted line, I guess, as being what it should be, what you expect it to be between. But is the solid line the average?
Yes, yes.
Fine. Okay, but then even then you would say it's yo-yoed up and above the average. If the blue line is the,
yes, it's steadily been going up from the thing, but not sort of statistically significant yet in terms of data points. Yeah, but we're monitoring it, and it's something that we've seen that it's slightly going up.
Yeah, I see.
So
it
we're still trying to
understand. Yeah.
Yeah, so we're still trying to understand, because usually it's something that it's all connected. So an incident happened, we respond. The first thing, we may offer medication, and sometimes people may refuse, and we have to make a decision whether that medication is given under restraint. And then sometimes with that restraint, you then go to the seclusion room if it doesn't de-escalate. But what we're seeing is the restraint, there isn't any much disparity if we compare the different ethnicities, but the seclusion and the so we're also trying to still understand the data as well. This is like unit level, but then there'll be differences at ward level. And what would we expect to see is maybe our intensive care ward, where people are the most unwell, the data, it's higher within that overall number. But then also looking at what does that compare with in terms of ethnicities. I don't know if that makes.
Yeah, no, it does. It does.
So that's in relation to our restrictive practices and how we are complying with mental health use of force work. We have also started a piece of work with a North East London Foundation Trust, which is a neighbouring trust, and also Oxley's Trust, which is another trust in London, because we are all grappling with the same issue. So we're using a forum to make sure that we are sharing good practice, but also learning from each other as well, because we're all trying slightly different things to cater for our local populations. All our services within the trust have got what we call a time to think space, and that space has all the restrictive practices, and our improvement work happens through that, and it includes service users and staff at all levels as well. And that's where we have the in-depth monitoring of the data related to specific wards, and then the unit, and then compare it with the rest of the trust. So the third thing that we wanted to talk about was the patient care and carer race equality framework. So this comes from the Advancing Mental Health Equalities work that is led by NHS England. So we were approached about 2 years ago to see if we wanted to be one of the pilot trusts to look at the patient carer race equality framework. And it's a recommendation from the Mental Health Act review of 2018. Ultimately, what it does, it recognizes that there is disparity in terms of access, outcomes, and experience for people of ethnic minorities within mental health services, which does link to some of the stuff that I've just spoken about. But this goes broader than just the restrictive practices as well. So we started that work with 3 other trusts in England, looking at piloting this. So what it is, it covers 3 main areas. So firstly, it's leadership and governance, which looks at statutory and regulatory responsibilities that the trusts have, organizational competencies, and then patient and carer feedback. So in terms of the leadership and governance, when we started this work, we also then looked at our internal processes, and we strengthened that to create a space where we look at impact of access, outcomes, and experience of our service users related to all the protected characteristics, but there's a space particularly for sort of racialized experience. And we're working this with our staff experience as well. There are some similarities in terms of in life as from an ethnic minority, but then we can go down into specifically the experience of being being a service user and what that feels like. So we designed this with our service users and our staff, and the work streams are divided into the children and young people, adults and old adults as well. However, it all does come together in terms of our equalities board. I chair a meeting called Making Equality Work, and it's at place. So I chair the City and Hackney one. So when I do the City and Hackney one, our forensic services, which is in Hackney, our City and Hackney services with Dean, our children and young people, then primary care, all our services, we come together to talk about all the equalities work that we're doing across all the protected characteristics for our staff and our patients, because technically we're all working with the same communities, regardless of the speciality that we have. The second bit is about engagement. So when we started PCREF, one of the things that we did is we sent out questionnaires to our service users and our communities about their experience, but also the things that we should look at. We engaged with so the East London Mosque, Coffee Afrique, so many voluntary services, our service users, our staff, to get trying to get as much input as possible. And through that, 3 things were identified that we are going to be doing, but also the other services are working on. And that's cultural awareness, which is what Dean was talking about. So that sometimes I think I know our service users feel that there's lack of cultural awareness and sensitivity to the differences. Now, it's not to say that any group is a monolith, so one thing that you do applies to everybody, but then just having that natural curiosity when we're working with people who are different to us, which also again links in to the thing about how our workforce is as diverse as possible. Staff knowledge and awareness, we think there's a gap, and our service users think there's a gap in terms of what staff need to know about how to consider catering for such diverse populations which we have in East London, and then partnership working, because a lot of how we can do this doesn't always sit maybe with the NHS. So who else can we co-opt to work with to make sure that we're linking in? And then from a local point of view, we're doing the trauma-informed work that I spoke to earlier, and then thinking about intersectionality, because again, not just one of the protected characteristics impacts. So a woman from an ethnic minority background may have a different experience to a man, may have different to someone who's disabled, and so forth. So there's something about we have to also be flexible enough to appreciate that the impact of our services can be felt differently depending on what other factors are impacting you. And at the moment, we're collating more information specifically targeted to children and young people, because they're also a group that experience services differently. But the question we're asking our service users is, what does good look like for them? This also ties into our equalities plan, which we developed, and I ran focus groups with our service users about what do you think we should be working on and concentrating on over the next 5 years in line with our trust strategy. And then finally is patient and carer feedback mechanism. So making sure that, so what we do today doesn't mean that's etched now forever, because service users said something today, so we'll do that for the next 20 years. So continually getting feedback and making sure that we're co-producing the plans or the change ideas that we want, because it might seem like a really good idea and come from a place where we want to improve things, but it actually will not work for all communities. And then finally, I suppose is thinking what we've learned so far, just undertaking the exercise of consulting with our communities. Firstly, accessibility. So when the initial NHS England questionnaire came and we tested it, there was something about the language within that. So we did quite a lot of work in ELFT to make sure that the language is accessible, which we then shared with other trusts. There is also a frustration from communities about the fact that over the last 20 years, there have been so many papers, so many research, so many consultations that ultimately, when you look at it, they're saying the same things. And so in a couple of years, when we feel it's not working, we'll send it out again. So people are quite tired of being asked the same things, saying the same things. There's survey fatigue as well. So people were just tired. Every other day there's a survey. But I think there's that thing about actually when you give people a survey, you then need to do something with it, because otherwise people don't want to engage anymore. Impact of COVID and lockdowns and the isolation that people have, but also when we started, some of the times we're engaging through the digital world like we are now, but not everybody has got access to the technology to be able to engage as well. But also thinking about the different groups, like I said, about intersectionality as well, which, so it's not just thinking about hearing from a racial point of view, but those groups as well belong to other protected characteristics which may impact on how they receive the services. There was something about the voice of children and young people. I think initially the first tranche of it was very aimed to adults and didn't naturally apply to children and young people. That's why we're doing the work to engage children and young people. And I said about the intersectionality. So there's some work that we've got in progress at the moment. We're trying to, yes, make sure that we're working on the racialized experience through PCREF, but also in the same hand, make it work with our wider equalities work as well, because there's something about how do we see equalities in absolutely everything we do, so that it's not a special project we do on the side, but features in all our work: access, service design, and also how people experience our services. Well, there's a lot to do, and I think this will take time as well, but the key is producing this with our communities, but also with our staff. I will stop there.
Lorraine, that's fascinating. Thank you very much. You can sense your passion, and very helpful. I also appreciate the transparency you bring in terms of the, informing us of the 2008 acts, and you're holding yourself accountable to that as well. So I very much welcome that. I saw Cllr Adebayo first, and then Cllr Samatar. So Cllr Adebayo.
Oh, thank you so much, Lorraine. And Dean, that was very informative. However, the first question is to Dean, because when Dean talk about the cultural awareness, the planning, training, he talks about training with outside bodies, working with the community organization. And at the same time, I'm wondering what sorts of training is available for the staff that are working within the system in terms of bridging the gap of inequality. And secondly, this goes to Lorraine. Lorraine talks a lot about what they are doing to promote diversity. And one of the issues, coming from ethnic minority myself, and one of the issue is the cultural diversity. How are we promoting this within the system, especially with the staff? Because this can be one of the reasons why a lot of people get ties within the system. So I leave it for that. And the last one is about the staff well-being. What in particular are you doing to promote the staff well-being working in this field? Thank you.
Okay, thank you, Councillor. Shall I come in and try and answer the first question, which is around the training offer? So what we're about to begin is rolling out some cultural awareness training, which I guess, and we're looking to train a number of leaders within our organisation, within our directorate, who will then go back to their teams and offer that across their teams. And it's a bit of a test. We'll see how that goes, and we'll learn from how that training approach works. And the other two boroughs in East London are doing something slightly different. Each of us working in partnership with local providers and local organisations to develop the training. But I guess the idea is to help staff understand their own assumptions around cultural awareness, and understand what they do know and what they don't know, and to develop an appropriate curiosity and interest in the ethnic and cultural background of the people they work with. So it's really about trying to see people not in the box of this person's a service user with a mental health problem, but this is a person who lives in this community, comes from this heritage and this tradition, and may see the world differently from how I see it. So it's about developing that sort of sense of seeing the whole person, understanding the cultural background that they have, and understanding what we don't know about that, and being prepared to engage in conversations around that. So we're trying this out. We're hoping that in the next month or so that the training will start, and it will be offered to all of our teams over the coming months. And we'll evaluate how it's gone, and we'll get some feedback from service users. It's co-produced and co-delivered as well.
Lorraine?
Thank you. So I suppose my understanding was that the diversity within the trust. So we embarked on race and privilege sessions, which Dean was talking about. This is part of our Respect and Dignity campaign, because one of the things we picked up on is sometimes we can say that we can only measure sort of racism based on the in-your-face verbal abuse incidents, but actually what we saw was microaggressions, and what was having the huge impact. So we had a series of work using our staff to talk about the experience of being an ethnic minority. So this is Lorraine as a Black woman in London, not just Lorraine as the chief nurse. And that was really powerful, actually, for people to experience what it's like to be an ethnic minority and then bringing it into the workspace. And all our services have got forums to talk about that with our staff so that we're constantly addressing it. We've also got something called the Freedom to Speak Up Guardian, where staff can approach anonymously to talk about some of their experiences as well within the trust. But we're very aware that the term ethnic minority can hide a lot because there's such diversity within that diversity, and there's a danger that we lump everybody together within that. We look at data as well in terms of our staff experience. So disciplinaries, for instance, we've been doing a lot of work to make sure that we've got a fair treatment process. And our data now is that you're no more likely as an ethnic minority to be disciplined as a white person, which it wasn't like that over the last couple of years. We've done quite a lot of work with that. But also, we like to focus on also celebrating, because sometimes it can feel like being an ethnic minority, you come from a deficit side of what you don't have and what you should have. But actually, there's something about how do we celebrate the communities that we have that have contributed so much within our East London communities as well, and sort of thinking about how we can learn from our communities. So we do that with our staff, but we also do that with our patients. In terms of the staff well-being, we introduced reverse mentoring. So there's something about senior people also being mentored by staff from different protected characteristics as well, so that from an individual senior point of view, you are learning about the experience. Because, you know, even as the senior people, as we're working, you can lose sight of that, even though that's not what you're trying to achieve. There's the mentoring offer that we did offer our, particularly our staff network, our ethnic minority network, in relation to staff to be supported, not that they should go and train because there's something that they need to gain, because we do know particularly ethnic minority staff have got the most training ever. Whether it translates to a promotion or progression, that's a different thing. And then finally, that trauma-informed care principles, we've taken them to think about how do we become a trauma-informed trust. So thinking about that in relation to all our policies, our employee relation policies as well, so that we're also not re-traumatizing our staff due to how we manage them, and making sure that there's transparency in how we look at our data in terms of staff experience. So all our staff survey results, we then break it down in terms of the feedback based on protected characteristics, and then our 5 staff networks help us in terms of what we need to do for practice to support people, and then all the other protected things like away day supervision and appraisal. And we're now working on something called Trialogue, which is looking at staff-related experience measures, which is similar to Dialogue, something we use with our patients as well, which will also start be able to tell us about people's experiences, and not just specifically what you do at work, but just generally, because we think if you're supported in that way, you're more likely to bring your whole self to work, and also it will have a positive impact on our service users.
Thanks, Lorraine. I'm going to take the next 2 questions together. So Cllr Samatar first, and then Cllr Turbet-Delof. So Cllr Samatar.
Thank you, Chair, and massive thank you, Dean and Lorraine. That was a lot of detailed and very passionate responses to some of the questions there. So thank you both very much. I wanted to kind of ask a 2-pointer, if that's okay, Chair. The first question, kind of going back into the specific groups and the way we're breaking it down in terms of like identity. There's been some concern for a long time about how the recovery outcomes for African and Caribbean heritage men in particular have been poor compared to the rest of the population. So I was wondering if you can touch on that a bit more in terms of what progress is being made. And the second one, and I'm really glad that you mentioned it a few times, both of you, the fact that the BAME community is kind of diverse in itself, and often there are minority within the minority, if that makes sense. And in particular, when you said race and dignity, that campaign is absolutely amazing. So I wanted to know, people who are from the minority community but identify as trans, for example, or identify as something that's not in the mainstream of what's available to service to everybody else, what support are being tailor-made to make sure that they're receiving that support that they get, but also that they've been given the dignity to receive that support adequately as well? Thank you so much.
Thank you, Councillor Samatar. And Councillor Turbet-Delof?
Yes, thank you, Chair. Good evening.
Yeah, I can. We might have some echo in the chamber when these are going, but I think that's not going to be unavoidable.
Okay. Hi, everyone. Thank you so much. That was a very detailed and informative report. I have two questions, if that's okay, please. And first, I just wanted to start by mentioning that this week is Children's and Young People's Mental Health Week. As I'm sure all of you are aware, it's very important to kind of say that I think all of us in here are working really hard to improve the support for young people and children. The first comment, let me just 1 second check. Are we okay with the sound?
Yeah, I think because of the issue we've got, I think we're just going to have to make do with members asking the questions. I'm sorry, it's the best we've got.
That's fine. It's two of me today. That's fine with the sound. Right. So first of all, just a quick comment. I wonder if the East London NHS Foundation Trust will consider replacing the acronym of BAME to global majorities, just simply because minorities becoming increasingly a triggering term in terms of, power and, all what it entails and what it means to different communities, especially when we're not seen and we are less. So it's very important, I think. I wanted to share that. Perhaps it's something to think about. My questions, I have two brief questions. One of them is related to data on, so let me get my question here so I get it right. Apologies. Right, so my first question is about readmission rates and support post-discharge of patients on antipsychotics. There is a growing concern of patients becoming codependent on antipsychotics and not being aware of the many side effects that it can have on the health and the recovery journey. Could we perhaps hear a breakdown of the support that is offered to people that are discharged on antipsychotics, on the action plan, including those that don't speak English, so to understand what is the provision provided for them and what is in place. Then the last question is related to cultural awareness training that you mentioned, which sounds fantastic. My question is language other than English being included in these services? And I'm just quite curious about the support you said for the staff. You mentioned that the staff are getting support. I'm wondering what sort of mental health support they also receive. Thank you.
Okay. So Lorraine and I'm now getting some feedback there. Lorraine and Dean, we're slightly going to risk of going over. So if I could possibly ask if you could, I know you've got sort of 5, including the global majorities question. You've got 5 questions there, but if we can try and sort of condense down the answers, because we've got other items on the agenda to get onto. So over to you both.
Shall I try and answer the question about outcomes and the offer around support for readmission? So there's the early intervention approach is increasing evidence to show that that comprehensive package of support at an early in people's illness improves their outcomes, and all the evidence we have locally is that we're able to engage much more effectively with people, particularly young men, I think was the question, from ethnic minorities in that approach, and break that sort of cycle of fear and that exists in those communities by that experience. So the outcomes for young black men coming through that process are much more positive going forward. They get a comprehensive approach of support, looking at their their psychological needs as well as their medical needs, looking at their needs to go back into education and training and really get their life back on track on their terms, and the outcome generally is much more positive if those interventions happen soon, early, and comprehensive. So, and I guess that follows on to the other question about what support is there. So everybody being discharged has a care plan agreed with them at discharge, and that the comprehensiveness of that will depend on people's needs and circumstances, but they will get a range of offers in terms of a key worker, support to look at issues that they've identified in their assessment, whether that be about education, about housing, about income, about engagement, social inclusion, and social engagement, really, sort of looking at groups and linking them into community activities. So there's a comprehensive offer, but it varies from individual to individual as to what they need and what they want.
And Lorraine?
So the training in relation to, I think there was a question, apologies if I've missed the question. There was a question in relation to what do we do for specific individuals. So for example, trans service users. So we're very fortunate, we've got passionate young people, and I think there's something special about young people actually understanding some of the issues relating to gender, relating to being trans. And so they actually are training our staff in relation to the terms, how to work with us. We've reviewed our policies as well, but we're also leaving it to individual decision making relating to bespoke care planning with individuals within our clinical teams as well, because I think there's something about people are not, like I said, monoliths. So there's something about how we make sure that it's also tailored to the individual needs. But we do have a policy and training and are supporting our staff in understanding that. There was a question about interpreting. We work with the language shop in relation to interpreting and translation, and they're very helpful. So when people are discharging, getting their medication, if language is a barrier, we can engage with them. We've also done a piece of work with some of our service users, have been getting trained to be interpreters as well. So we're also supporting them to get work in interpreting, but it also links to making sure that we're also employing members of the local community who can speak some of the local languages as well. Notwithstanding, we do need formal interpreters, because we also understand that that can actually be quite a stressful thing for a member of staff to engage in if they have to be translating for local communities that they belong to. So we're mindful of that as well. So there's quite a few things that we're doing to make sure that language is not a barrier to receiving the appropriate care. And the global majority, I agree with you, we're in the process of changing it. We started with our staff network, they're just changing their name, but yes, it's going to filter through to all our terminology, notwithstanding that some of the reports that we have to do and how that information is given back to us, it still says BAME or BME.
Thank you. Right, I see Cllr Adams, I've got Malcolm from KOMP, and Cllr Patrick as well. So, right, can I do the councillors first? Can I ask councillors, can we just keep these questions succinct and brief? So, Cllr Adams.
Thank you, Chair. Thank you for the presentation. Very informative. So my question is on, you talk about early intervention support for users. So I'm just wondering, are there any criteria for people to qualify for this early intervention? And what happened after, you said the intervention is between 2 to 3 years. So what happened after 3 years to those people that are receiving this intervention? And my last question is the need, you said that, page 16, you said the need to increase access to advocacy. I'm just talking about funding. Do you have enough funding to do that?
Thank you, Cllr Adams. Thank you, Cllr Adams. And Cllr Patrick?
Yeah, I've got 2 questions. Sorry. One on the use of seclusion and seclusion and tranquility. These are for the BAME communities that it's going up. And I just wondered if you had any, you've broken it down further so that we could see which particular parts of the communities, as rightly said, the communities. Yeah. I can't see it unless I don't know who Jamie are. I can see the groups or culture groups in here in Hackney, and I imagine that these people with their mental health is like anybody else. Now what we're doing with that community and other communities, and certainly we look at things that we in making sure that our services are culturally.
Thank you, Councillor Patrick. And Malcolm, is your question as set out about the St Leonard site?
I've got two questions, but they will be short.
Right. So if you keep it succinct, we've really got to move on if we can.
Yeah, sure. I appreciate that. Thank you very much for the presentation. I just want to ask, in relation to the forensic service, I just wonder, because there are quite a large number of patients in the forensic service who are there for many years, sometimes 3 or 4 years, and I just wonder how you ensure their inclusion in the work you're doing in relation to ethnicity and gender and other issues. My second question is one that I sort of submitted, but really it's about a health inequalities issue in relation to the fact that people with dementia and people from CAMHS who use a CAMHS service are sort of sent out of borough, and this seems to be consistent with problems of inequalities. The fact that is they are separated from their families and their friends and their other cohorts of people they mix with, and that seems to be inappropriate. And I feel very strongly that those services should be brought back into the borough and, for example, provided in St Leonard's Hospital or other sort of centres we have within Hackney. Those are my questions.
Thanks, Malcolm. For the final round of answers, I don't know if it may, Lorraine, do you want to start off?
Yes, so apologies, I couldn't really hear the second question. There was a lot of echo.
Is that from Councillor Patrick?
Yes, I think.
Okay, so the questions were in terms of the seclusion and data. Have we broken it down into different community groups, minority ethnic groups, as opposed to just an overarching BAME or global majority header? Has it been broken down into different particular groups? The second question was in particular focus on the Turkish and Kurdish community, which we have a large cohort of people from that community in Hackney. And the third question from Councillor Patrick was in relation to, I think, sort of really bespoke and specific personal situations people may have if, say, they've come from a war zone, and the degree to which torture or which matters are tailored to that. So those were Councillor Patrick's questions.
Okay, thank you. So in terms of breaking down, we've got the information available. So at local level and at ward level, we can look at specific groups. However, we do know, particularly for seclusion and restraints, it's more likely if you're Black African or Black Caribbean for you to experience that, although we sometimes get the flip side, particularly within our Tower Hamlets services in relation to Asian men. So the breakdown is available, but generally, for the purposes of looking at it trust-wide, we do pull them together. In relation to the sort of traumatic experiences, that's what I talked about earlier about trauma-informed. So being really mindful in our care planning and our interventions of adverse experiences that our service users would have gone through. So that is catered for from in the care planning point of view. And particularly, I think seclusion and restraint generally, we get that. So people who may have been restrained or held down or abused, particularly even as children, those early years, we're trying to do this work to stop ourselves from re-traumatizing people. Ultimately, actually, we'd rather not restrain or seclude anyone at all, but being mindful if you have to do that, making sure that we are mindful of those experiences. I'll touch on the forensic one. So I'm a forensic nurse. I worked in the John Howard Center for about 13 years. And the John Howard, there's a cohort in relation to service user engagement within that. So some of this work and some of the ideas actually comes from the John Howard Center. As you know, particularly quite a number of the patients come through the criminal justice system. So there's a high proportion of the service users are from the global majority as well, but they are completely engaged within this work. So when we do that making equalities that I was talking about within Hackney, that includes the forensic services as well. It's all the ELFT services within a particular borough that we include. We don't leave forensics out.
Thanks, Ray. And in terms of, maybe Dean best, in terms of the services provided out of borough, possible use of the St Leonard site, I mean, is there any, on the horizon, are there any plans to possibly bring things more in borough or not? Or is that just the way things are for the time being?
There aren't any plans as far as I'm aware. I mean, CAMHS, I think we're both, CAMHS and dementia, I guess it's an issue of scale, isn't it? We've got, I think, 15 acute CAMHS beds and 12 intensive care CAMHS beds in Newham, Surrey, East London and wider London. To try and bring that back to a borough level, it would struggle to be viable. But actually, we're very fortunate that the majority of our young people are treated locally in East London if they need inpatient admission, which is different from the experience of, unfortunately, many young people across the south of England. So we have got local East London provision, which works very well. And the issue about trying to localize that is about scale. And the same is true with older people's services. We had a standalone older persons ward in the lodge in Hackney for many years, but it became unsafe to run a single ward, and was much safer and much better care in a more joined up service in Mile End.
Thanks, Dean. And Councillor Adams' questions. I'm afraid, Councillor Adams, I was too busy playing with my sound to write down what your questions were. And I'm not sure they entirely heard them. So could you just remind me? For early intervention, the criteria for support, Dean.
So the only criteria is that it's someone's first presentation of a psychotic illness. So we try and offer it to everybody when they first appear in crisis and it's clear it's their first psychotic presentation, and the 2 or 3 years is a comprehensive offer, as we've described. At the end of 2 or 3 years, if they still need services, they'll be transferred to either one of the relevant neighbourhood team, depending where they live and where they're registered as a GP, or to our recovery service. So at the end of 2 to 3 years, we hope they're in a much better place, but if they still need mental health services, we transfer them to the relevant team within the borough.
And for the increase in advocacy, is there funding?
That's a good question. We need more funding. I think that's true. Yes, we and I think the service is being recommissioned as we speak. But I think we do need more resources. Yes.
Okay. Well, thanks for the frankness there. Both of you, thank you very much indeed for what was a very interesting presentation. I think a few of us remarked we can sense the degree of leadership and passion there from both of you, and hugely impressive. I think perhaps other organisations and trusts could also learn from the work you're doing. So it was great to hear that, and thank you very much indeed. So thank you. I'm going to now move on to item number 5, and I may even take, it's the same group of people presenting, take 5 and 6 together in the interests of time. So item 5 was in relation to the soft facility services contract at the Homerton. So that's the porters, cleaners, security staff. And item 6 is possibly the future of community diagnostic centres, so the ability to do MRI scans or X-rays in borough or a more local level. For both of those items, we're joined by Louise Ashley, who's the Chief Exec of the Homerton and our place-based system in Hackney, Breda McManus, who's the Chief Nurse, and Rob Clark, who's the Chief Financial Officer. Welcome. So just in terms of the first item, just in terms of the soft facilities contract, the brief background was 2 or so years ago, it came up for tender. There was a great degree of concern that there wasn't proper sick pay and rights afforded to those members of staff. We're grateful for the Homerton at that stage then essentially levelling up and providing that. At the point there was discussion or questions asked about, well, why can't you bring it in-house? There was a very fair reply saying, hang on a minute, if we were going to do something like that, it would require a lot of planning. We can't just do that at the point now. Totally understand. In the interim, we've had BARTS, the biggest grouping in the country, as I understand it, bringing theirs back in-house. I think that Shane has sort of said to us on previous occasions, yes, there might be some, certainly in the short term, greater cost pressures, but hopefully in the longer term, there may be other advantages as well. And so here we are, possibly 2 years out, maybe 3 years out of you possibly looking at what you do with your contracts. So here's us sticking our nose in, saying to you, are you going to give some thought now to the possibility of insourcing? So with that, that's why we've done it, because we remember that it can't just be done on the hoof. And if you are meaningfully going to do it, it needs to be, the wheels need to be start doing now. And what can you do to learn from BARTS to possibly start considering it is the sort of challenge to you. So Louise, do you want to kick off? Or
yeah, I will. And good evening, everyone. It's really nice to be here and listening to that fantastic presentation and discussion earlier. Thank you, Councillor Hayes. Yeah, I've heard a bit about the history, and I suppose just to reassure everyone that we're really committed to including our partners, our ISS partners, all the staff from there in all the work we do, and the wellbeing work that we do with staff, and the various kind of stuff over winter that we've done to support staff around their own sort of personal stresses and finances and stuff. We always include all of our staff, and we think of everybody as all of our staff, which is a good start, isn't it? There are quite a lot of estate issues at the Homerton that we're looking at the moment, and Rob's with us, and Rob's been in post a few months now. He's in charge of making sure we spend the money properly, but he also has the job of overseeing our directors of estates and the contracts. So I thought it'd be useful if Rob just gave us an update really on the process. I suppose from my point of view, just that, yes, I'm extremely committed at looking at how we might do things differently in the future. We, as you know, have to follow a very rigid legal process as far as our procurement, etc. But there's certainly a commitment to look at that differently. So I'm going to hand over to Rob, who knows a lot more about these things than I do.
Thanks, Louise. Evening, everyone. Yeah, so probably worth me just saying that although I've been in post for about 4 or 5 months, I was actually the Deputy Chief Finance Officer at Barts Health prior to my joining the Homerton, so I have first-hand experience of the process they're going through to in-source their soft FM services, and indeed are in constant dialogue with them around how that is going. And indeed, if you've seen the local press and indeed BART's own notifications recently, they've brought in first and foremost their security services into their own employment, and that has gone down incredibly well. Services are I'm led to believe have seen no impact, and in fact the staff are happier, which is one of the primary aims of the work. So effectively, we are watching with great interest how that process is going. In fact, we're going to meet with them regularly and get lessons learned from how that process is working. You're right, Shane has articulated, and I don't think Bart's sort of shy in sort of saying this is going to cost them more money, because obviously the packages that we offer staff in the NHS are more generous than the independent and private sector. And that's part of the reason that we're looking to bring them in-house for the benefit of the staff that work in our hospitals, and they should be treated in the same way as our own staff, I think is the main premise of that. And indeed, maybe rather cheekily, but we did also ask them, should we look to go out to tender for these services, and that will happen at the beginning of 2024, to allow us to make sure we meet the contractual renewal date in 2025. Would Barts be in a position to maybe bid for that, given that they've bought their own services in-house at that point, which may be a nice, easy, discreet way of doing that ourselves. So we are already considering options and looking. I don't want to put pressure on Barts to say they'll do that now, but it would be a very easy or an easier way of doing that, having gone through this whole process themselves as they are at the moment.
I mean, that's interesting, Rob. I appreciate. So essentially, they get brought into the NHS family via Barts, not necessarily through the Homerton, which achieves the objectives.
Yeah, it's just an option we're considering. It may not happen, but one thing to consider.
I can imagine.
And of course,
go on. No, you go, Louise.
Yeah, just obviously looking at the value for money bit, because whilst we don't want things just to be to do with money, unfortunately, any extra spend, it's not just about justifying it, but we have to then look at where else that comes out. So I think because of the scale, then we may be able to get much better value for money for City and Hackney if we do it through a collaborative. But we're a little way off that, but yeah, we're in those discussions.
I'll let Cllr Adebayo come in, but I'm only going to let that one question on this, because otherwise I think some people's passions could this could sort of take over, and we've already overrun on the previous item. So I will bring Cllr Adebayo in. But then if you would have to go out in 2024, which essentially is next year at some point, and obviously there's discussions got to be had with the board here, and obviously your board may take a different view than the Barts board took on something like this, and I appreciate I don't know if there's all those considerations as well. But is there a possible point that maybe either it would be later on this year or early next year, maybe you could come back to us and give us an update on where we're thinking, either in terms of collaboration, or in sourcing, or I suppose if it's still, and obviously I think you get the sense of what this committee, and for the reasons you said, would feel, and sort of explain more of your thinking, where you're at. But particularly if things can evolve on a collaborative basis, that would achieve that objective. So the one question, Cllr Adebayo.
Thank you, Rob, and thank you, Louise. A quick one. I did hear Rob mentioning the cost is going to cost more, and if we look at it in the short term, it might cost more, but in the longer time, we're going to save more money. And at the same time, I'm wondering where the union stand on this particular issue, because bringing the service back in-house, I think it's going to, encourage the staff to be more productive in terms of being happier, in terms of better future, better terms and conditions, better pay, and happy staff. It's a good outcome. I leave it.
I'll quickly come back on that. I met with the staff side and the unions just last month to discuss this issue, and they are very clear on their views on this and would like to see the services brought in-house for the reasons you've just described. So we remain very clear on their views, and indeed some of the stories they were able to tell me around the conditions that the staff in ISS are under leads me to believe that that's exactly why we should be looking at bringing this in-house. And you're right, it will cost us more, and we do have to be careful about obviously value for money in terms of public purse, but you're right, we need to think about staff retention, how they work with other people within our organisation who are under different conditions. So we'd like that parity and equity as well.
Okay, thanks. All right, well, what I will do is I'll leave it there. Thank you for that brief update. We'll move on to community diagnostics, but I would ask then if we can come back either towards the tail end of this year, but certainly what I'm keen for us to do is not come back at a point that it's completely past decision making point, but come back at an appropriate point, either tail end of this year, to let us know thinking. And I appreciate there'll be some degree of commercial confidentiality on figures, but also I suppose what we could learn in a quite abstract way from Bart's is pro rata per staff how much more it's costing, and just give us some idea, because if you are saying to us at this stage it costs too much, well, how about, you know what I mean, just to give us some idea about what's in play there. But I'll leave it there, and if we can just move on to community diagnostic centres. And again, just to summarise, it looks as if from the evolving sort of updates we've got is that Lower Clapton Surgery moving to part of Clapton Girls' School. Lower Clapton is got down to the final shortlist of what is a new, not recycled money, but new pot of money, as I understand it, for diagnostics. So when should we hear whether Lower Clapton has been or has not been successful? And what would that mean? A new building or using the old building?
So we should hear later this month. The main issue is that recycling is a good term there, because there's been a number of pots of money allocated nationally to these endeavours, and in theory the North East London pot of money is very much needed, and as such the available funding to undertake the works at Lower Clapton is not there at the moment, but they're looking to try and recycle underspends from elsewhere across the capital to be able to fund that. So it may be that isn't forthcoming, in which case...
You're chopping up a bit, Rob.
You're frozen, Rob.
That scheme may have suggested elsewhere. Oh, sorry, can you hear me?
You're freezing a bit. Yeah.
You're freezing a bit. Just can you just summarise that last bit again?
Yeah, sorry, I was going to say that there's only a certain amount of funding available at the moment. We're trying to recycle underspends against this national pot funding from elsewhere to fund the Lower Clapton proposition. If that's not forthcoming, then it may be that the bespoke model that's outlined in the paper is the preferred choice, because it is within the envelope that we've currently got. So we are very keen to get this. This would be an exceptionally good service for us to undertake. We have an absolute need for these sorts of services, and to allow us to continue to treat our patients in a timely manner. So we're pushing incredibly hard for this. It would be within the current building. It would be quite a lot of additional work. One of the premises of the funding is that it shouldn't be on a hospital site, because we want to try and treat patients in the community, and that's why this is a really attractive offer, we believe.
Fine. Okay, thank you. And if it was to be the lesser spoke option, was that the one that was going to go somewhere outside Hackney that I saw? Yes. So it's looking like it's an alternative situation. It's not both. It's one or the other, and that's funding dependent. Absolutely, yes. And the Homerton would essentially get the contract, for want of a better word, or be in charge of running this. So this is something that we run by the Homerton. Yeah, and it would be really complementary to our staffing models, because we'd be allowed its distance and proximity to the hospital allow us to run joint rotas, which would allow us to recruit more staff and really be an attractive offer for staff, which we do struggle with sometimes in this area. So it would be amazing to get it.
I just think, I think, I honestly can't see why we wouldn't get it. Now, I know everyone's probably saying the same who's on the list, but if you look geographically, it just makes perfect sense. Plus, you know, we've got a really good kind of record of diagnostics. As you know, our kind of weights are less than most places. The problem is that, you know, sometimes when you're doing things very well in an area, you get slightly overlooked for areas that perhaps aren't doing things as well, and it's thought they might need more help. But we're really pushing the kind of, you know, this isn't about kind of leveling down or whatever, that actually this is really important for City and Hackney. So
thank you. And
fingers crossed.
Thanks for that. If you let us know when you know,
We will.
for any clarity, that would be very helpful. And then can I just lastly just deal with the update where we are on the St Leonard site? We have got one of the St Leonard's councillors, or one of the councillors who's St Leonard's falls in their ward here, Cllr Adams. The position was the Homerton was looking at the possibility of an asset transfer, but about 8 days ago, I don't know whether it was expected or not, national government stopped allowing asset transfers from property services to trusts. And so essentially, as I read that helpful update, is that is now currently essentially dead in the water, and that essentially we're back to a degree of uncertainty. It's certainly out of our hands then as to the short-term or medium-term future of St Leonard's. Is that a fair update?
Yeah, that's a good summary. Rob, did you want to add anything else to that?
It is accurate. I would have to say though that previously we've had issues with the relationship with NHS Property Services, and we felt that was because they were wanting to sort of go down the route of a sale of the asset to potentially the private sector. We had no indication of that. It was just an assumption, because they weren't really engaging with us, and their valuation of the site seemed to be hugely different to our own, which was part of the stopgap to allowing us to take on the asset. Since about 2 months ago, they have it's a change of leadership as well. They've really started engaging with us and the ICB, and we're having regular conversations now about the actual use of the site, about how we can use the admin space better, how we can actually churn over some of the more clinical space, upgrade the accommodation. They've invested £3 million in the site this year, full window replacement, for example, and are now setting up a big program of work with us and the ICB as to how we can use the site better. So it isn't great news for the asset transfer, but it is better news in terms of they're now engaging, they're at the table with us about how we can use the site better.
And I got a slight sense from the briefing note from Louise that in some instances, perhaps understandably from the Homerton's point of view, you were pulling out some office-based services there to consolidate in other places, but still some core healthcare services would still be, some Homerton healthcare services will still be provided from that site.
Yeah. And it's, you know, it's an excellent site. The staff, the clinical staff that work there love working there. Our patients love going there for obvious reasons. You know, it's not just about the history. It is actually a really, it's just so much less kind of stressful for a lot of people going there rather than traipsing up to the Homerton. So we're really keen to, as you know, to sort of see how we can further develop our clinical services there. I think we're trying to make sure that any kind of space we have that is that useful for our patients, that we keep it for clinical services, because obviously administrative services can afford to be elsewhere. But yeah, no, I mean, I do think it's quite positive news with NHS. I mean, we were disappointed, to be honest, but I think it is positive that they are now paying some attention to it and, you know, wanting to, as we do, to sort of progress to putting more services in there.
And just to add, one of the things we're having a conversation about is identifying additional clinical space, because we've got ambitions to expand the ARC services based there. And property services are engaging with us on finding that space in the relatively short term as well. So yeah, that, as I say, conversations have really turned a corner in the last couple of months.
Okay, thank you. So it's been a bit of a irony that the national picture has suddenly changed. Okay, so very quickly, I see hands from Sally Bevan, who's the interim head of Chief Exec of Healthwatch, and then Malcolm. So if I could take these questions very quickly, put them out to answer, and then I'm going to move on to the last item on the agenda. Sally.
Yeah, thank you. Very quickly, as you probably know, the future of St Leonard's is part of our 3-year strategy at Healthwatch. I see from the briefing that the conversations are now taking place about what services could be offered there. Just wanted to say that we'd very much like to be involved ourselves as a Healthwatch, but where possible to support local people to come and be a part of those conversations. So I don't know if that's something we could pick up offline, but I would be
Excellent.
Thank you.
Thanks for that offer, Sally. That's fantastic.
Thank you.
Thank you. We'll take that as a comment. Malcolm?
I think the St Leonard site is a fantastic site for the future development of our services in Hackney. You know, going forward for the next 50 years, I think, you know, what a gem it is to have that space for development. And just one other thing is that, you know, discharge from hospital is a big problem. I mean, A&E department is really blocked at the moment. We need step down facilities and we need rehab facilities. You know, because some people can't go home and you know get their rehabilitation there. They need another place to do that, and we used to have a step down facility which we lost, and I really think that St Leonard's is an ideal site for that kind of development. Thank you.
Thank you, Malcolm.
No
and
question, but a statement.
Yeah, no, that's fine. I'm going to just bring in lastly Cllr Turbet-Delof, and then I'm going to close off this item. So I'm just going to take my sound down so I don't echo. Go on.
Thank you so much. Just very briefly, it's really great news to hear that St Leonard's stays in the community, and that just, you know, hearing what you say, possible opportunities for development. It certainly is a treasure for Hackney. There has been real concerns of people thinking that maybe that was meant to be or given for properties and etc. So this is really relieving news. Just as a suggestion, maybe with my mental health hat role, and also because the DFE today released you're probably aware of this report about the tsunami that they call in the mental health lack of services for young people. It would be amazing if St Leonard's was also considered for maybe increasing mental health support as well. Just sort of like throwing the little seed there of suggestion. Thank you.
Thank you. Thank you.
Thank you. I think if I can just take all those three as sort of helpful comments and people's understandable appreciation of the St Leonard site. Thank you, Louise and Rob. That's very helpful for those updates, and no doubt we'll see you both soon at a future meeting. Thank you. Don't feel you need to stay for the next item. Thank you very much indeed. Then can I lastly move on to the item number 7 on the agenda, which is the new hospital discharge funding scheme. We welcome Helen Woodland, who's our Group Director, Georgina Dibber, who's our new Director of Adult Social Care and Operations. In short, there was money announced both in, I believe, or in November, if I've got it right, of just under 2 million and for Hackney, and then national 200 million, again, if I've got that right. Helen's, I'm not sure if I have.
500 million in November, Councillor Hayhurst.
I'm going to be quiet and let Helen present on the implications for Hackney and the update about where this money and how this money is being spent. Helen.
Okay, thanks. So as you have said, we had an initial announcement of £500 million worth of funding in November. This is not unusual for us as a system, or any system actually. So what we used to call this was winter pressure funding. And I think probably what we acknowledge is that our winter pressures now last year round, but they are particularly more enhanced going into the winter months, and that's traditionally when we've had kind of short-term funding injected into the system. So there is an established process because of that, because we're used to getting this funding on a kind of annual basis. And I think what's probably really important for the committee to be aware of in Hackney is, one, that we are consistently one of the best performers in terms of length of stay for residents certainly in the Homerton Hospital, and two, that we have very established processes for working together with our health partners and with Homerton Hospital in particular around how we best use that money. And what I would say is I think our consistently good length of stay seems to me to demonstrate that what we invest the money in is what has been most useful. It's what has helped. So we sent you a brief report. Apologies, this came out very late and I'm aware, but there's a number of different schemes that we invest in. If I draw people's attention really to a couple of those, I know we've just been talking a little bit about step down and kind of intermediate care. So we have a number of flats in our housing with care scheme that are designated for step down from hospital year round. And we've used some of this funding to increase that number. We've also used some of the funding to put in place a team of social workers and occupational therapists and other kind of community nursing and therapy assistants to ensure that people then don't get stuck. So there's one thing discharging someone from hospital into a step down flat. What you then want to do is get them back to their own home or their preferred care destination as quickly as possible. So that move on team has been quite crucial to maintain that flow, to mean that we've got that provision there. So this is a plan that's worked up with our health partners. We deliver it jointly, we agree jointly what we're going to invest the money on, and we monitor the outcome of it jointly. The only other thing probably to talk about is you will have seen there was a further announcement then for another 200 million nationally. And that funding was very specifically around how to increase the number of residential and nursing beds within the sector. That's not necessarily one of the issues that we face in discharge in the City and Hackney system. So we rarely have people waiting for care home beds. That being said, we have worked with one of our existing care home providers to increase the number of beds very slightly, so to 3 on a short-term basis. And I'm monitoring very closely how those beds are used. But we haven't taken a large chunk of that money because, as you rightly said in your questions, Councillor Hayhurst, we would not want to put people into restrictive care or nursing home beds when they don't need it. So I'll pause there for any questions. I'm sorry, I should have said Nina Griffiths has joined us as well from...
Sorry, yes, I was meant to introduce... Sorry, Nina, I didn't introduce you at the start. I saw you joining. Welcome. So, Helen, the position as to why Hackney doesn't have as much a problem as other local authorities in terms of nursing and healthcare beds is what? We've got a younger population or not? Or is that not? What is it? What is it? Why?
So I think it's probably complex as a question. I think possibly because we don't have as many nursing and residential facilities in City and Hackney, culturally our social workers are much more comfortable in supporting people back into the community. So we try whenever possible to keep people in their own homes or close to their own community. And given we don't have the option of directing people to residential and nursing placements as readily in our system, our social workers work very hard to ensure that people go home with the support that they need.
Okay, thank you. Councillor Adebayo, I think I saw you first.
Okay, thank you, Ellen. Just one or two questions. Firstly, about the care home staffs. Are they equipped? Because now, newly discharged, they will need like nursing care, medication, and all that. Are the care home staff equipped to handle this? That is one. Secondly, if newly discharged patient refused to go to care home, what happened?
Okay, so just to be clear, Councillor Adebayo, we are not using this money for any care home staffing. We're using it for a move-on team, which is largely social workers and occupational therapists to support people who've gone into step-down facilities. I think you're right to raise the question of the wider training and support for carers, whether that's care home staff or home care staff. Yeah. And I think that's probably a broader question around how we support our care workforce to develop. And sorry, the second question was if someone didn't want to go to a residential or nursing home. So legally, we look at what's known as the least restrictive option. So for us, a care home or a residential placement would absolutely be the last resort. More often than not, actually, we have the opposite problem in that families, not necessarily individuals, families are pressing for their loved ones to go into residential or nursing care because they believe it's the safest option. So we would never want to force someone to go where they didn't want to go. And we do occasionally have delays where people refuse to leave hospital because they don't agree with the plan that we feel is the right plan for them. That's why our social workers are highly qualified and experienced, and they then work with that family to resolve those issues. We've never, as far as I'm aware, had a situation where we've had to go to the Court of Protection because we believe so strongly that someone should be supported in a way that they don't wish to be supported. So usually we can resolve those issues.
Councillor Samatar?
Thank you.
Thank you, Chair, and thank you both very much. The question that I have kind of links us back to the first item on equality. You mentioned the team, a specialist move-on team made out of very different professionals. I just wanted to know if you could please break down the diversity of this team, taking into consideration, are we taking into consideration cultural competency, intersectionality, etc., to make sure that they are trained appropriately to deal with the needs of each of those people. And the other one was, you mentioned, and I really support the idea of people being supported to go back to their homes and be supported in their homes as much as possible. I fully stand by that. What happens then if, however, a person doesn't have a home to go to? As often we've got a lot of people who are in situations where they're receiving care in a place of, professional safety, but then when they're released and have to be discharged, they don't have a home to go to, and we've got a huge housing crisis. So how does all of that marry into still providing the adequate support for the person?
Sure. Okay. So, Councillor Samatar, I'm going to have to come back to you with the exact makeup of that team because, to be honest, I don't have it to hand. What I can say to you is that 86% of all of my social work workforce come from local communities and from global majority communities. And also, it's a core part of social work training. So, all of our practice is designed around personalisation. And that's really what social workers are trained to do, is to understand the needs of the individual, the wants of the individual, and how we can best support them. But happy to come back to you outside this meeting with the makeup of that actual team. So your second question, sorry, I've lost the thread slightly. Can you remind me of your second question?
Yeah, it was just the idea of supporting people after discharge, but instead of those with the home, what we do with those people who are not able to unfortunately have that access.
Okay, so yeah, we do have that as an issue, not very often. So if you think of people going into hospital, that they usually came from somewhere. We occasionally have homeless individuals who then go into hospital who have care needs, who we then have to accommodate when they come out. More often, and you'll see on the list of interventions we're investing in, and a growing issue for us, is actually people who are subject to self-neglect or hoarding, and actually their home environment isn't suitable for them to return to. So we've specifically got step-down flats partly for that purpose, and we've invested in what we call hygiene services, so that would be deep cleans or support around those issues. And we also have provision both for homelessness, either in specific accommodation for homelessness, where we can then assess what their longer term accommodation requirements are, but also for people with no recourse to public funds, because that is also an issue for us in this area. So just to reassure everyone, if you have care and support needs on your discharge from hospital, it is our statutory duty to meet those needs. And that may also involve providing accommodation of some sort, so often it's temporary accommodation, to be able to meet those care and support needs.
Helen, the extra flats, are they in Hackney, the extra step-down flats?
Yeah, so they're actually all in our housing with care schemes. So not only are they in Hackney, they are in our in-sourced care provision that we directly run and manage as a council.
How will we, with the sort of pressure on housing, how are we able just to sort of buy up some more internally? I mean, can you just talk us through this? I thought
Sure.
there would be pressure on them.
So we don't buy them. What we have is nomination rights, because they're mainly run by RPs. And what we've done is agreed with those RPs that rather than, it's quite a delicate issue, but you imagine with my older people schemes, there's a relatively high turnover because unfortunately people pass away. So what we have agreed with the RPs is that where there are empty flats, rather than nominating people to move into them on a more permanent basis, we will use them short term for step down.
So in other words, this creates an understandable pressure, but the council has many different pressures upon somebody that may be on a housing waiting list, vis-a-vis being used for step down care.
It really shouldn't, because the housing with care schemes, the nominations are specifically for people with care and support needs. And actually we have probably just about the right amount of those. We also, being completely honest with you, Councillor Hayhurst, have a couple of schemes that are not hugely popular for people who want to move into those on a kind of a longer term tenancy. So often run with a handful of voids. So in a sense, they're flats that weren't being used and could not be used for general needs housing because of the nature of the schemes.
Just on this subject, just so we can understand it more. I mean, I think you've previously sort of indicated that we're still housing, whether it may be through care or residential, or maybe step down, a significant number of people outside boroughs still. And if I've understood it correctly, it would be if there was that magic money tree, and greater housing resource to actually house more of those individuals in borough. Is that right?
Yeah, absolutely. So we still have a significant number of people in particularly residential care. So if you have a nursing level need, you will need nursing care. There's really no way around that. For some individuals who go into residential care, if we had alternatives to residential care in borough, such as extra care supported living, we believe we could accommodate them within Hackney in a less restrictive way.
And so it's that, and just going back to the point that Councillor Kennedy sort of quite candidly was raising maybe at the last meeting, in terms of sort of your challenge to us as politicians, or to your colleagues, and the competing demands, is that what your view you would take is that if we could build more or resource more of those supported living options in borough, that would be better for the residents because they'll be in their place of borough, and would that be more cost effective as well for the borough?
Yeah, on average. So individual placements will vary because the cost of care for individuals is built around the individual. But on average, if someone goes into a residential placement, the entire cost of that placement, including what we call the hotelling cost, which is the cost for accommodation and food and such, comes out of the adult social care revenue budget. If someone has their own tenancy and moves into their own flat, as you say, the priority for us is it's better for them. They're local, they're within their own community, they're more independent, but also it enables them to access welfare benefits like housing benefit, which would then cover the cost of those hotelling costs, not out of the adult social care revenue budget.
So just sort of hypothetically, if you could, how many would you, I'm just trying to get some sort of idea of scale here. If you could, how many roughly, I mean, in an ideal world, how many new supporting living units would you have in borough?
So I'm hesitant to say, because I think that's a piece of work that we need to take away and do some actual modelling and projection. What I can say is we've got, give or take, 400 people that are in residential placements out of borough. And if you were going to kind of avoid that flow, that continuous flow, you might be looking at maybe half to 2/3 of that amount that you could then provide in borough.
Okay, all right, thank you. And just following on from that, I mean, are you I mean, obviously, you know, you've got to work with other directorates within the council as to whether that's even possible for a multitude of reasons. But are you even looking up that sort of piece of work? Are you doing that sort of basic research to sort of make a spend to save case?
We are. So we've asked our population health hub that's based in public health to start helping us with that kind of demographic modelling. And we are working with our colleagues in housing and regen to understand how that might be kind of slotted into the overall capital build programme going forward.
I mean, of course, the other option is that the pension fund can invest 5% in borough.
I think all of those things are on the table, and I think there's probably growing awareness, certainly among colleagues and politicians, that this might be something we might need to look at in a slightly different way, with different kind of partnerships and commercial arrangements, but will have long-term benefits for our residents, and actually will have a positive effect on the overall council budget.
Yeah. Okay. No, thank you. I mean, I don't know. Have you got a timeline? I'll bring Malcolm in a second. Have you got a timeline for when you would have worked up a more? I appreciate discussions would have to be had, and you know, there's timings of when these things are brought to scrutiny. But have you got a timeline of when you'd have a more worked up sort of facts and figures on this that you might be able to inform us more about?
We haven't yet, Councillor Hayhurst. What we have got is an agreement that, as you know, at the moment we're looking at kind of the efficiencies that we need to make going forward for the medium-term financial plan to balance the budget, and that this is a project we should look at scoping as a cross-council project. So that's broadly been agreed this week, really, and there's a meeting next Friday to look at how we start then taking that forward.
Okay. Well, I mean, just from those of us, for example, who do sit on pensions and things like that, so we can sort of, I mean, I think as you appreciate, the more informed we are on how things can operate in that way, I think the more helpful it is to promote it. So, Malcolm.
Yeah, I don't know if you could answer this question, but can more be done to unblock the Homerton? And the reason I ask this question is on Monday this week, there were 59 patients waiting for a very long period of time inside A&E. There was 4 patients waiting for psychiatric beds, 4 for paediatric beds, and 2 for 2 women waiting for beds. The 95% target for 4 hours was actually met at about 65%. So, I mean, there's a really serious problem there. But I know it's not your jurisdiction, but I just wonder if more can be. Sorry, Louise, you're there. I just wonder if more can be done because you know those are even though Homerton is one of the best in London, those are pretty bad figures.
So, I mean, I'd probably defer to my colleagues on that, Malcolm. What I can talk about is the kind of length of stay and the delayed, what we used to refer to as delayed discharges. So, actually, on Monday we had, give or take, 15 delays. But the majority of those actually were out of borough. So the pressures on the system, the entire system at the moment, are immense, and I appreciate that. Probably unprecedented. And one of the challenges that we're facing now that hasn't been so acute in the past is actually we have a number of people in the Homerton who aren't from City and Hackney area, and that makes them more tricky to discharge. Obviously, we're working with neighbouring authorities and colleagues and colleagues in the Homerton to do that. But I would say that really the system is under quite significant pressure, although we are starting to see it ease slightly. But the remainder of it, I think I'd probably have to refer to Louise, if that's all right.
Louise, is it the case that a lot of the more recent pressure is out of borough? Because you're a victim of your own success in the sense you're now taking.
Yeah, I mean, it's the flow of patients, thanks to the work that Helen and her teams do, and because of our excellent primary care services, the flow of patients through the Homerton is extraordinarily good compared to colleagues. The issue is, of course, northeast London is pretty blocked up over winter, and you probably wouldn't want to go and wait 6 or 7 hours at Whipps Cross in Leytonstone when you can come down to the Homerton and wait a lot less. So those sort of it's a really tricky one because everybody's entitled to good care, but those the sort of increase because of out of area patients, certainly our staff feel that very strongly. But you know, they are patients in need, and that's our job, is to treat anyone that's in need. So we don't turn people away, obviously. We've also had a few other problems, I think, over the last couple of weeks, you know, as well as winter problems. We've had a few IT problems and various things going on. But yeah, as you say, Malcolm, you know, our performance is really high compared to the rest of London, which when we do have our worst days, you then think, gosh, London's not doing so well. But yeah, no, our flow generally is really good. And our system of assessing that, we have a sort of escalation system, and we are generally at the lowest level in the system of escalation, which is a good thing. So.
Thanks, Helen, for that. And I think we've obviously got you coming back next month, maybe a bit more of a conversation about what we were just asking about there, about how Hackney can possibly bring future-proof for adult social care going forward. Just before I wrap up, while we've got Louise there, Louise, where are we? I mean, we're going to ask this just completely off agenda. We'll obviously pick this up with colleagues at the Inner North East London Scrutiny Commission. But in terms of the staff allocation to place, to the Hackney and City Place, as sort of all the new job descriptions have come down, how many sort of full-time posts on the sort of what used to be the CCG side have we now got compared to what we had previously under the CCG? I mean, the idea of sort of what was termed to us as this 80-20 split, where 80% of the money would be spent at or we place. But of course, if you haven't got the staff to do that, you can't do much of that, and you can't do much commissioning.
Exactly.
So where are we up to on how it's flushed out?
Yeah, I feel I've had an evening of not being able to actually complete any total decisions in the NHS. I do apologise for that, but this is another one where we still haven't got the final decision. The consultation paper for that was due to come out about 2 weeks ago. Then there was a change to policy from the Department of Health, re-looking at the finances at NHSE and further decisions around that. So it is due out very soon, but it hasn't yet come out. As soon as I know those kind of allocations, I'm happy to come back with Nina and go through what the structure looks like. And
so the ICS can't tell us what each place has got because it's waiting for guidance from above.
I think it's more to do, it's a kind of consultation around the whole staffing structure. It's not just around the place-based. So they can't just separate out the place-based staff from their central functions because of the kind of way that staff are, well, obviously some staff's jobs will be at risk. And so it's a whole consultation process. It's not kind of at the moment just right, that many are going to City and Hackney.
Fine. So it's still a moving feast. Okay. So yeah,
it is. I'm afraid. Sorry.
Okay. All right. No. Well, it's obviously. I mean, we're obviously keen. We appreciate your point that you don't want all the responsibility with no staff.
No, absolutely.
But at the same time, we obviously would. You know, we've seen the benefits of commissioning locally, and
yeah, definitely.
If we can have staff to be able to do that,
yeah,
that's really important. So we're obviously keen that we get as much. I'm obviously grateful we've got Nina, but obviously going from a place where we had 20 or 30 full-time equivalents at the CCP, we're keen to retain as much staff as we can.
Yeah, and I think the other point to that really is, for me, it's not just that the staff, not that just we're allocated staff, but that the decision making can happen at place level, because what we don't want to see is that staff are sort of pseudo allocated to us, but then we have to go all the way up the decision making tree and back down again before we can make any decisions about anything locally. Yeah, so that's what we're sort of pushing for as well.
Good. Okay. Well, that's welcome to hear. Okay. Well, we've overrun, and so with that, then I will thank you, Helen, again for that update on the wind support. And with that, then we will bring the meeting to a close. I've got to agree the minutes from the last meeting. Can I agree them, colleagues? Thank you. And then I haven't been notified of any other business. And so then with that, we will close the meeting. Thank you.
Thank you.